There are no conflicts of interest to disclose for this talk. This talk will cover a number of topics in a brief period of time. We're sharing this talk with a sports psychologist who will talk more about concussion and its aftermath. And the purpose of this introductory element of the talk is to describe some of the terminology and classification of head injury in children, how the head injuries occur, their mechanism, algorithms for initial triage, imaging and management, certain controversies about this hot topic of concussion, and also a brief overview of where the field is going in terms of studies to improve our management of pediatric head injury. So let's start with terminology and classification of head injuries. There are three ways people have traditionally classified head injury, and they are not necessarily overlapping. You may be in one category in one classification and in another for a different way of classifying. So the most common way that we classify head injuries in the hospital is by pathoanatomic type. And this is what you get on a radiology report or on a pathology report from autopsy. And this generally follows the pattern of where and what an injury is. For example, epidural hematoma. Where it is in the epidural space, and what it is a hematoma. And many descriptions pathoanatomically of head injuries follow that general sort of categorization. Head injuries are also classified by severity, and this is most often based on the Glasgow Coma score, which we'll cover in a moment, into mild or minor head injury, moderate head injury, and severe. But the field is moving away from this for a number of reasons that we'll touch on in a moment. Finally, you can classify head injuries by mechanism, and these classifications are largely in the realm of bioengineers, prevention experts, automotive engineers, and forensics. And this involves the forces that are instrumental in causing the head injury, largely categorized by whether they're impact forces, inertial forces, or a combination of both, and we'll go into a bit more detail on that. Now, with respect to severity of injury, the Glasgow Coma score is the most common method used. This is a scoring system that was designed to compare acute severity of injury among centers. It really never was designed to follow an individual patient over time, yet that's how it's used in many neurologic disorders, even beyond those that are traumatic in nature. It has three subscores for eye-opening, for motor responses, and for verbal responses. And the range of scores that are possible in the Glasgow Coma score are 3 to 15. There are modifiers that are sometimes used if a patient is intubated or otherwise unable to perform in a particular category. The mild, moderate, and severe ranges have to do with which of these number ranges you fall into. So the lower you are, the worse your score, and that's why the lower numbers are severe and the higher numbers are considered mild. The reason that we're moving away from this classification is that the Glasgow Coma score is not the whole story. It's influenced by medications, often as part of pre-hospital care, and it also doesn't give the entire neurologic exam. For example, you can be completely paralyzed on one side of the body or in the legs or from the neck down and have a perfectly normal Glasgow Coma score. So it doesn't really tell you about the strength of a patient, the symmetry of the exam, and other really critical features. So it's insufficient to really describe a patient and often influenced by pre-hospital care. Babies under about the age of 2 who are pre-verbal don't really get assessed well by the Glasgow Coma score. We use the so-called infant face scale, or CHOP, infant coma scale, for our children under 2. It relies on facial expressions in response to handling or noxious stimulation as a substitute for verbal, and therefore is more objective, and also has the advantage of being able to be performed accurately in children who are intubated. The initial triage and management that we use at our hospital is similar to that used in many hospitals, where there's a set of basic data that you need to start deciding what category a patient may come into with respect to the risk of deterioration and the need for immediate intervention. So in the history, what we need from the emergency medical technicians or people in the emergency department who have taken the call is, when did the injury occur? What are the basics of the mechanism, the kinematics of the injury? What was the energy, the speed with which something was moving, the height from which a patient fell? Did the patient strike the head? Is there evidence that there was even involvement of the head at all? What was the best exam that observers were able to obtain at the scene of the injury? Was there a loss of or change in the level of consciousness? What was the basic Glasgow Coma score at the scene? Was there asymmetry of the motor exam or of the pupils? And importantly, did the patient move the legs? Did someone actually witness this and document it? Because sometimes when patients with a more intense injury come in and they've been pre-medicated, if that history wasn't obtained at the scene, it may be a big question mark for some time. Then we'd like to know whether there were things that can exacerbate an injury with respect to the pathophysiology that we're treating. Was there apnea at the scene? Was the patient in shock? Was there a prolonged extraction during which there really was no good exam or vital signs? Are there concomitant injuries that could affect the patient's overall well-being? Was resuscitation needed? These all can make the injury worse and add additional insults that we need to treat. Once the patient arrives at the hospital, we'd like to know what's the exam via a standardized tool. As mentioned, the Glasgow Coma score is important but insufficient, so we also need a good motor exam comparing the two sides of the body and upper and lower extremities, as well as cranial nerves, the pupils, and other basic things that one does routinely in a neurologic exam. Finally, there's a component of imaging, and we need to know not only what does the imaging show, but what was the interval of time between the injury and when the image was obtained. This is critical because some injuries can evolve, and the closer that the injury was to the actual time of obtaining the image, the more likely there is a risk of the injury having progressed radiologically since the time the image was obtained. Then what, of course, surgeons want to know is whether there's a mass lesion that needs to be dealt with right away once this initial assessment is done. So let's spend a moment going through some of the details of this assessment. Let's talk a bit about mechanism. It's quite clear that the types of force that are applied to the head and the neck and other parts of the body determine the types of injuries. So this is why how high the child fell, what distance the head to ground covered was, what part of the body hit, was there something that might have cushioned the fall, what was the surface, and so forth. So these mechanics of falls are of critical importance, as are the mechanics of things like how fast a car was going, how far a child was thrown, if a car struck a child on a bicycle or as a pedestrian, and other elements of the mechanism. This is true for infant falls in the home, as well as motor vehicle falls and everything in between. We largely break the forces involved into contact and inertial forces. So contact forces are those things that occur from the head being struck by an object or striking an object. And these occur to injure the surface structures. The greater the force, the deeper from the skin the force extends into the skull and brain underneath. Inertial forces refer to those types of forces that occur from the brain moving once the head is put in motion and then stops. And these, by and large, cause more diffuse injuries. It's important to understand that most injury scenarios include both contact events and inertial events at the same time. So a head is put in motion, stops suddenly. The force of the stopping against the surface of the head causes contact events, and the motion of the brain within the skull causes inertial injuries. There's a constellation that the clinician can then use, taking into account the history, the physical exam, and the imaging, which helps you predict which complications your patient may evolve, and you can then intervene to avoid them. Let's talk a bit about why mechanism is important. You can predict from the mechanism what type of injury is likely to occur in a given patient. So in general, for younger children, a fall less than 4 feet, which we estimate as being at shoulder height of an adult, so a child who's being held at shoulder height, that's about, for most children, a 4-foot fall. And these can cause linear fractures, ping-pong fractures, and epidural hematomas. Once a child is above shoulder height, you're holding the child on your shoulders, it's off a balcony, it's off a bunk bed. Now you get into the realm where children can get basilar skull fractures, depressed skull fractures, focal subarachnoid hemorrhage, surface contusions, and occasionally subdural hematomas. These also include things like falls downstairs and sports and recreational injuries where the initial velocity is higher, so the force is higher. Once you get into things with wheels and speed, largely motor vehicle trauma, and these include pedestrian injuries, passengers in cars, children on bicycles or scooters, now you have a great deal of additional force. And now you typically can get all of the above injuries, plus you're into the realm of forces that can cause subdural hematoma and diffuse axonal injury. So let's use some examples that show that the events that happen with an injury, the mechanism, can help you predict what complications may occur. So we're going to show 3 examples of injuries that were mild by the Glasgow Coma Score or Infant Face Scale score, but they were all low height falls that caused epidural hematomas, and they were all contact forces. So here's a 10-month-old, every pediatrician's fear, who fell from a parent's bed while the mother turned around to get a diaper onto a wooden floor. The baby cried immediately, was easily consoled, and fell asleep for his nap. But a few hours later, when he didn't wake up, he was found to be unresponsive. He had an epidural hematoma associated with a skull fracture. And this is not a high-force injury. It's just that a low-height fall in a baby with a thin skull can crack the skull or bend the skull just enough to tear the middle meningeal artery, and this is a true surgical emergency that can have a bad outcome if not recognized early on. Here's one with more force. This is a 13-year-old who was hit by a car while riding a bike in a parking lot. She was briefly unconscious, but then she was awake and talking, but she had vomiting. So she was brought to the emergency department, had imaging, and had this epidural hematoma, also associated with a skull fracture, which takes a bit more force in an older child of this age. However, this is a motor vehicle involved and a bicycle, so there's more velocity. Now there's more likelihood of having additional injuries. And you can see on the opposite side, there is a contusion from the inertial forces of this child's skull and the striking of the ground. So this is predictably going to have potential to have more than just this focal injury, but have multifocal injury. This epidural is a true surgical emergency, as was the last one, because of its proximity to the temporal lobe and the adjacent brain stem. Here's another contact injury that caused an epidural, but here's a delayed epidural. So this is a 4-year-old child who fell backwards from a swing, a classic scenario for this particular type of injury. She was awake and alert, cried, rubbed her head, and then went about her business. But over the next day, she got sleepier and vomited at home. She had an occipital skull fracture from that impact, which tore some of the venous structures here and caused a delayed appearance of a venous epidural hematoma. These are slower to evolve, but this is a dangerous location because it's in the posterior fossa where you can get brainstem compression and acute hydrocephalus. So we know, however, that most children with low height falls, low energy mechanisms, impact energy mechanisms are fine. The vast majority are not like the 3 that I just showed you. So there has been a great deal of effort to try to reduce CAT scans because of the concerns about radiation exposure, especially in children who are more susceptible early in life. It's been estimated that there are nearly 3 million CAT scans done on children in the United States per year, and there are those who have estimated that maybe as many as 1 in 1,500 children who are exposed to a standard, and not necessarily a reduced dose CAT scan, may develop a malignancy because of that scan. There have been many campaigns to try to reduce this, including the Image Gently campaign, which is one of the most well-known. There are additional risks to CAT scans if a child is very agitated and needs to be sedated, and of course, it's expensive. There have been a number of decision rules that have been designed to try to help pediatricians in the office and emergency department practitioners to decide who needs a CAT scan and who doesn't need a CAT scan. Those decision rules, by and large, have been better at helping guide who doesn't need a CAT scan than they have been at guiding who does need a CAT scan. And here are a number of acronyms for many of the studies: Nexus, Chalice, the UC Davis group, the PCARN group, and the CATCH algorithms. All of these take into account the history, the mechanism of injury, and the exam. And by and large, most of them suggest that if a child looks well, has remained well since the time of the injury, there are minimal scalp findings, it's a low energy mechanism, and it's not an infant, you probably don't need a CAT scan. This is an example of the PCARN CAT scan decision rule algorithm, which is the one that we use in our hospital. This is broken down into children under age 2 and children age 2 and over. The reason that it's broken down that way is that in young children, the best predictor, because the exam can be difficult or nonspecific, is whether or not there are focal impact signs, because skull fracture is a risk factor for intracranial hemorrhage. Interestingly, the algorithm tells you that you can get to CT scan not recommended, but when it gets to who needs a CAT scan, both the below and over 2 years of age say physician experience needs to be brought to bear. One of the trends has been use of rapid MRI instead of CAT scan, and the point of this is that you can get additional information on a rapid study but not use any radiation at all. And the way we do this at our hospital is the child is in the scanner, and the parent or caretaker or sometimes technician will go into the scanner with the child to both comfort and also immobilize the child to some extent. These scans are designed to be acquired extremely rapidly, so even if the child is moving about, you usually get enough information to answer your surgical questions. There's a rapid T2 scan for structure, typically in 3 planes, and you can also include the upper part of the cervical spine, which is helpful for looking for spine injuries. And this takes typically 90 seconds. There are also blood-sensitive sequences, susceptibility weighting, or epi sequences. These typically take about 2 minutes. And there are other sequences which I'll show that have been done for research purposes. This is an example of a rapid MRI sequence done as part of the TRACK TBI study, which we'll mention a little bit in a moment. This entire scan sequence took just about 5 minutes, and it includes very nice imaging for T1 for structure and also for acute blood, diffusion for any sort of contusion or ischemia, tractography, and other sequences that can be used for research or other purposes, and blood-sensitive sequences, which are extremely sensitive for blood. You can see here that in this sagittal view in a young child, you get most of the cervical spine. And while it doesn't give you fine detail, it gives you enough to make some statements about edema in some of the ligaments or interspinous areas, the bones, or any evidence of cord compression. Some centers, including ours, have used a rapid MRI as an initial study. Here's a 6-month-old with a fall from a camper bench, so it was about a 3.5 foot fall, head to ground. He had some vomiting on the day after injury and was persistently irritable. So this is his MRI, and what you can see here is that there's a thin subdural hemorrhage that the arrow points to. Here's the coronal view showing that same thin subdural. Here's the cervical spine, which looks fine. Here's the susceptibility weighting, which shows that thin hemorrhage as a black line. 2 months follow-up, the hemorrhage is gone and the susceptibility has also gone away. It turned out that this child, because of the presence of a subdural from a low-height fall, which is somewhat unusual, was worked up for bleeding disorder and did indeed have von Willebrand disorder. MRI can also be used as a follow-up exam when you have a child with an initial CAT scan with a lesion that needs to be followed for progression. So here's a child that fell from a jungle gym, had a small epidural hematoma, had a follow-up MRI, which showed that the epidural hematoma had enlarged somewhat and had persistent headache and an episode of vomiting, so this was evacuated surgically. Here's a football player with a thin subdural, and here's the follow-up with the thin subdural. We'll see this youngster again later in the context of football injuries. And this is a child that fell onto a concrete floor in play and had a very thin subdural, and here's the follow-up image that shows the extent of that thin subdural and one on the contralateral side. This eventually resolved, but it took weeks to resolve, and the child had some persistent symptoms. One question about the use of MRI is how will you detect skull fractures? When you're trying to reduce radiation, you can do skull films to get skull fractures, although digital skull films can be sometimes difficult to detect skull fractures. There is an ability to get a skull CT without the brain, and it's somewhat grainy for the brain. You can see the size of the ventricles, but you can't see fine detail. But just imaging the skull can give you very nice three-dimensional reconstructions that show skull fractures. So if there are particular reasons to make that diagnosis, a skull CT is even lower dose radiation than a regular reduced dose brain CT and less penetration into the brain. This is a 3-month-old who was dropped from the parent's arms, so that's about 3.5 or 4 feet typically, onto a tiled kitchen floor, and with one hit got bilateral parietal skull fractures, which is a known entity. Once you have your imaging data, then you can categorize the child into having what we call swelling or deterioration-prone injuries versus non-swelling prone injuries. And these have different management pathways because each has a different degree of risk. Let's spend the rest of the time now talking about the vast majority of children who have head injury, which have head injuries on the mild end of the spectrum, or the so-called concussion spectrum. There have been many specialties involved in this, from sports medicine to rehabilitation, trauma surgery, engineering, trying to design better surfaces and helmets and also understand the mechanisms of these injuries, basic neuroscientists trying to understand the pathophysiology and risks of these injuries, neuropsychology, neuropsychiatry, people involved in imaging, and people in the clinical neurosciences. So my talk will be given from this perspective, really from just outside the clinical neurosciences realm. So let's start with some common questions about concussion in the pediatrician's world, which has become one of trying to clear children for return to school and return to play without a lot of data. So here's a true or false question. There is good evidence that physical rest after concussion is important to recovery, and we'll answer these questions with some evidence in a moment. And here's another question that comes up often. True or false, most cases of catastrophic injuries after a second impact are associated with brain hemorrhage. And most pediatricians, when asked this, will say that this is false. So let's talk about definitions. What exactly is a concussion? Well, the definitions have changed over time and over the decades, and also among specialties. So-called sports concussion rarely includes loss of consciousness when people look at series of children injured in sports. Usually there are multiple impacts involved. Sometimes you can't tell. In fact, in up to half of patients, you can't tell that there was a particular impact that caused the injury, and symptoms may be delayed hours to days. This is a relatively new description of what the term concussion has been used for. What we in our field have seen as the use of the term concussion are typically children that show up in the emergency department in the hospital or in the pediatrician's office. These are usually single events. There may be other injuries. These may be children who are involved in motor vehicle trauma, falls from bikes, and other sorts of things. There's often a loss of consciousness, and it's usually a single event rather than multiple events. It's become clear that while people use the term concussion to refer to both of these entities, these may not be the same thing in terms of pathophysiology or even letting clinicians talk to one another. This is why we have advocated for the use of the term concussion spectrum, just to get at the fact that people are using the terms differently and they may not be talking about the same thing. This is a research paper done from a cohort of athletes wearing instrumented helmets, and the trainers diagnosed concussion, and it became clear that it wasn't necessarily consistent how people were defining this term. So the goals of this part of the talk are to review how guidelines for management of any entity are made, but then we'll talk specifically about concussion guidelines. We'd like to talk about the quality of the data in these guidelines, and then finally provide recommendations for how to use this kind of information. Concussion has generated many guidelines. These are just a smattering of examples, and there are many more than these. So let's talk about the different types of guidelines that are available. There are consensus documents and there are evidence-based medicine paradigms. Consensus documents are often led primarily by one discipline. They fill a need when it's a topic that needs some sort of guidance by the clinician, but there may not be much hard data. They may be more or less peer-reviewed when published. Sometimes they're published as supplements from a professional meeting. Sometimes they're published by a given specialty. And they may or may not have a rigorous peer review process. The other end of the spectrum are the evidence-based medicine paradigms. These make an attempt to use objective data versus biased or experiential data. They may have loose or relatively strict inclusion criteria for those pieces of data and reports that they include. And also, there may be guidelines that arise with this paradigm from one field or from multiple fields. One thing that is worth keeping in mind is that guidelines documents generally are very attractive to journals, so they can get published people need them, and so they may or may not have the same rigor as research, basic science, or even clinical research papers. So let's talk about evidence review guidelines. This is a process. The process may vary from one evidence review guideline to another, but they are all designed to try to have objective review of the data. These take a lot of work, a lot of time, and a lot of resources, and often there isn't much that comes out of them because there may not be much data, but they can create a list of gaps as research targets. They may promote standardization of care if people quote them and use them, and this is very good if the evidence is solid, but it's a potential negative if there is little evidence, but something comes out in a guidelines document so everyone adopts it without questioning whether the evidence it was based on was very thorough. It isn't clear that most practitioners fully understand what guidelines mean, and more specifically what they don't mean and can't say in terms of your management. So what are guidelines for concussion trying to do? There are three main goals, and it's not always clear to the clinician what these goals are. One important guideline, and in fact the target of a lot of legislation, is to try to prevent the so-called second impact syndrome. This is most often associated with a small subdural hematoma, which presents clinically like a concussion. You saw this child's MRI earlier. This is a football player who came in with persistent headache after what was thought to be a concussion, but in fact he had a thin but extensive subdural hematoma. This didn't require surgery, but should he have returned to play without this being detected, what we know is that some of these children rebleed and then have catastrophic injury from increased intracranial pressure and some sort of cerebrovasomotor tone abnormality that is still incompletely understood. Most second impact syndrome cases, when looked at carefully, in fact have had extraaxial hemorrhage, subdural or subarachnoid hemorrhage as part of their injury. The second reason to have guidelines is to try to prevent prolonged physical, cognitive, or emotional symptoms after a concussion. Not after hemorrhage per se, but now we're talking about a standard concussion without hemorrhage. It's still unclear what one needs to do to prevent these prolonged physical, cognitive, or emotional symptoms. And finally, there's been a great deal of interest in concussion about preventing late effects decades or years later, such as dementia and emotional decline. It's even more unclear what kind of guidelines one should use to prevent these late effects, which are incompletely understood. The Zurich Sports Concussion Consensus Conference guidelines are one of the most widely quoted concussion guidelines, and we are now up to version 4, which came out in 2012. The difference between the early versions and version 4 is that these have become more strict. This is a very careful and thoughtful group, largely driven by sports medicine, that has tried to come up with practical guidelines by a consensus approach rather than an evidence-based approach. There is a guideline in there about how to diagnose a concussion and a specific definition. And again, in these contexts, concussion is defined not by a blood test, not by an imaging test, not by anything objective, but mostly by what a patient complains of and occasionally by what a patient looks like. In the most recent version 4 of this recurrent consensus guideline that comes out of a conference is that the cornerstone of concussion management is physical and cognitive rest until the acute symptoms resolve, and then a graded program of exertion prior to medical clearance and return to play. However, in this version, the authors go on to say, the current published evidence evaluating the effect of rest following a sports-related concussion is sparse, and they recommend further research to evaluate the long-term outcome of rest. The optimal amount and type of rest is needed. So they've backed off a little. While they still say this is what you should do, they acknowledge that it isn't clear that there's evidence to support that this is what you should do. In contrast, the American Academy of Neurology came out with a consensus statement in 2013. This was a strict evidence-based review looking at pretty much all of the English literature on this topic based on particular subjects and questions. And what this paper and guideline suggested is that the data are insufficient to show that any intervention cognitive rest, physical rest, any sort of cognitive rehabilitation, any sort of vestibular rehabilitation, that anyone enhances recovery or diminishes long-term sequelae post-concussion. They conclude that on the basis of available evidence, no conclusions can be drawn regarding the effect of post-concussive activity level, either cognitive or physical, on the recovery from sports-related concussion or the likelihood of developing chronic post-concussive complications. So you can see that when the criteria are strict, the evidence is clearly quite sparse. What about impact testing or other computerized neurocognitive tests? There's no good evidence that when the scores have returned to baseline, you are no longer at increased risk of increased problems from another impact. That is, if the injury is subcellular, but your cognitive function has returned to normal, that doesn't imply, it doesn't guarantee that your risk of an increased problem from a second concussion has gone away. We really don't understand why some people are susceptible to these increased problems. And while neurocognitive score returning to some baseline makes some clinical sense, the fact that it means that you have no increased risk has not been established. Many times pediatricians are asked, when should a child stop a sport or so-called retirement? How many concussions is too many? It isn't clear from current evidence that it's the symptomatic concussion or the trainers diagnosing a youngster as having a concussion rather than the number of impacts that you've had, or whether it's some combination or one or more in a given individual patient. It's been shown from some of the helmet accelerometer studies that individual players in football get hundreds to over 1,000 impacts per player per season in college football. What we do know is that repeated hits are probably not good for you based on gathering evidence from long-term effects studies. And this is especially true if you already have learning issues or you will depend on higher cognitive function in your career or otherwise in your future. We can't yet tell who's susceptible to late effects such as dementia, Parkinsonism, or psychological problems. It isn't clear whether some people are particularly susceptible based on their genes or other factors. So the bottom line is that there's no clear answer to when you should retire from a sport or change sports. I tell families that this is a decision they have to make on an individual basis based on the available information, understanding that we don't have good information to guide this question. Our recommendations are that you shouldn't have another impact if you're still symptomatic, particularly with headaches because of the possibility of a missed small hemorrhage. And this is really to decrease the risk of second impact syndrome, which is extraordinarily rare but catastrophic when it does occur. Evidence for physical or cognitive rest is weak at present. Exercise has many health and wellness benefits, so I personally don't restrict my patients who have had a concussion from working out or having physical exertion. If it makes their symptoms worse, they should back off just because nobody likes to have symptoms, but I don't personally believe that there's evidence to suggest it's harmful. That is a controversial topic and other people disagree. I think in terms of sports participation, each individual family needs to weigh the benefits of play or participation against the potential risks. And there are many alternatives to contact sports such as track, crew, and my favorite, fencing, which has virtually no significant head injuries. These are all fantastic sports for athletically minded children. So since we don't have all the evidence, how will we get better at treating, triaging, and counseling pediatric head injury patients? The next generation of head injury research studies are not prospective, double-blind, standardized tests. They're, in fact, databases using the so-called common data elements established by the National Institutes of Health to do comparative effectiveness research. And there are several of these ongoing. TRACK-TBI, which I mentioned, stands for Transforming Research and Clinical Knowledge in Traumatic Brain Injury. There's an ADAPT trial, which is for kids in the pediatric intensive care unit with intracranial pressure monitors. And there's a large multi-center study out of Canada called the Pediatric Concussion Network. We are always happy to see and enroll your patients in some of these trials because our hope is that by pulling all this data together, we can look at large numbers, looking at things like genomics, imaging, detailed neuropsychological follow-up over time to try to answer some of the questions and give the pediatricians some more evidence on which to base their recommendations.